Hello everyone. Today we'll be discussing hepatocellular carcinoma. Basically refers to a cancer whose primary origin is the liver. Hepatocellular carcinoma is a primary tumor of the liver. It constitutes more than 90% of the primary tumor of the liver, and it occurs in approximately 85% of patients that are diagnosed with liver cirrhosis. Hepatocellular carcinoma is now the fifth most common cause of cancer worldwide. The etiology of hepatocellular carcinoma includes hepatitis B, hepatitis C, alcoholic liver disease, and non-alcoholic liver steatohepatitis or non-alcoholic fatty liver disease. Pathophysiology. So liver cirrhosis is a significant step in viral carcinogenesis for hepatocellular carcinoma. So basically what they're saying is first the liver needs to undergo cirrhosis, thereafter viral carcinogenesis occurs. So this integration of the hepatitis B virus genome into the host genome is the primary pathogenesis for oncogenesis in hepatitis B virus. Insertion of viral genome in telomerase reverse transcriptase promoter sites of the human genome results in mutation accounting for 60% of hepatocellular carcinoma cases. Chronic inflammation in chronic hepatitis C virus infection with subsequent fibrosis, necrosis, and regeneration contributes to hepatocellular carcinoma development. Molecular markers that are noted in liver carcinogenesis include viral structural and non-structural proteins, which are NS3, NS4A, NS4B, NS5A, and NS5B. Histopathology. So hepatocellular carcinoma is a malignant tumor of the hepatocytes. Cytological features depend on the differentiation of hepatocytes. So they can be well differentiated, going all the way to poorly differentiated. The trabecular architectural pattern is the commonest. Other patterns that you may observe include pseudoacina, that is acina with proteinaceous material, compact and sarcomatoid. So histology may show variation according to the differentiation of the tissue. So they can be well differentiated, moderately differentiated, and poorly differentiated. So as you can see on the diagram on the side, so well differentiated, you will notice that the cells are smaller than normal and there is minimal nuclear atypia, and nuclear density is 2 times of a normal liver. Then when we go to moderately differentiated, so these are larger tumor cells with more eosinophilic cytoplasm, pseudoglands, distinct nucleoli, ball, and giant tumor cells. Then when we look at poorly differentiated, so these are large tumor cells with hyperchromatic nuclei, prominent pleomorphism, may have spindle or small cell areas. Then on history and physical examination, the presentation of hepatocellular carcinoma is dependent on the stage of the tumor and the background, if there is cirrhosis or not. So there will be non-cirrhotic related hepatocellular carcinoma. So these are usually going to be asymptomatic in the early stage of the disease. However, if it's cirrhosis related hepatocellular carcinoma, so patients are going to present with symptoms of decompensated liver failure. So these include worsening of jaundice, pruritus, hepatic encephalopathy, ascites, palpable mass in the upper abdomen, fever, malaise, weight loss, early satiety, abdominal distension, and cachexia. The commonest presentation of hepatocellular carcinoma is abdominal pain. Symptomatic patients may present with variceal bleeding, intraperitoneal bleeding, obstructive jaundice, pyogenic liver abscess, and hepatic encephalopathy. Then of notice, the most common extrahepatic metastasis of hepatocellular carcinoma is to the lung, intra-abdominal lymph node, bone, and adrenals respectively. So that's in the order in which metastasis occurs. So usually the lungs, followed by lymph nodes, abdominal lymph nodes, bone, and the adrenals. So when you suspect a patient has hepatocellular carcinoma, what are the steps you will take in evaluation? So you start by performing liver function tests that include bilirubin, alanine aminotransferase, aspartate aminotransferase, alkaline phosphatase, which we call our common liver enzymes, which are ALT, AST, and ALP, and albumin may be elevated on the initial evaluation. Then elevated international normalized ratio, which is the INR, prothrombin time PT, thrombocytopenia, anemia, hyponatremia, or hypoglycemia may be noted. Patients with advanced HCC, chronic hepatitis, or cirrhosis-related HCC are likely to present with the above findings. Patients with early non-cirrhotic related HCC may present with normal liver function tests on the initial encounter. Then patients with paraneoplastic features of HCC could present with hypoglycemia, hypercalcemia, and erythrocytosis. Other lab investigations that are used to evaluate the etiology of hepatocellular carcinoma include hepatitis B surface antigen, anti-hepatitis C virus antibody, alpha antitrypsin level, copper levels, and iron saturation. Then we also check for serum alpha protein, which is a marker for hepatocellular carcinoma. Then on imaging, so hepatocellular carcinoma may be diagnosed with ultrasound, CT, or MRI. So on ultrasound, you determine the size, morphology, location, and vascular invasion of HCC. And this is usually the initial diagnostic test for imaging that's done, followed by computed tomography, which is our CT scan, and then MRI. Liver biopsy is not routinely done. That is because there is a chance of seeding the infection into nearby structures. So feeding the cancer cells into nearby structures. Then we look at the HSCC 8th edition staging system for hepatocellular carcinoma. So we use the T and M staging, where T stands for tumor, N for nodes, M for metastasis. So when we look at T1A, that is solitary tumor that is less than or equal to 2 centimeters with or without vascular invasion. Then T1B, solitary tumor more than 2 centimeters without vascular invasion. So of note is most likely in the T1 there won't be vascular invasion. Then when you look at T2, solitary tumor more than 2 centimeters with vascular invasion or multifocal tumors. However, none of them should be above 5 centimeters. Then we go to T3, which is multifocal tumors, at least one which is more than 5 centimeters. Then T4, single tumor or multifocal tumors of any size involving a major branch of the portal vein or hepatic vein or tumor with direct invasion of adjacent organs other than the gallbladder or with perforation of visceral peritoneum. And when we talk about original lymph nodes, so NX means original lymph nodes cannot be assessed. N0, no regional lymph nodes metastasis. N1, regional lymph node metastasis. Then distant metastasis, that's M. M0 means no distant metastasis, and M1 distant metastasis. So when we look at the stages, so stage 1A is T1A, N0, M0. Stage 1B is T1B, N0, M0. Stage 2 is T2, N0, M0. Stage 3A, T3, N0, M0. Stage 3B is T4, N0, M0. Then stage 4A is NET with N1 and M0. Then stage 4B, NET with NEN with M1. Then treatment or management of hepatocellular carcinoma, so it's dependent on the stage. So the treatment modalities include surgical resection, liver transplantation, tumor ablation, transarterial therapies, and systemic chemotherapy. Prognosis, so 5-year survival of hepatocellular carcinoma is 18% and is second to pancreatic cancer. The prognosis of patients with HCC is dependent on the tumor size, differentiation or grade of the tumor on histopathology, severity of the underlying liver disease, presence or absence of metastasis, and tumor extension to adjacent structures. Hepatocellular carcinoma with high levels of alpha-fetoprotein is associated with poorly differentiated HCC, and it confers a poor prognosis. Patients with hepatitis B-related HCC and positive serum hepatitis B antigen are associated with poor prognosis and a high risk of higher recurrence of HCC. High levels of serum hepatitis B virus DNA are associated with a higher risk of HCC and recurrence. Diabetes mellitus is a risk factor for the development of HCC and is also associated with a poor prognosis. Complications. Hepatic complications of hepatocellular carcinoma include hepatic encephalopathy, portal vein thrombosis, worsening ascites, variceal bleeding, obstructive jaundice, and pyogenic liver abscess. Intraperitoneal bleeding is a life-threatening complication of HCC, and in such a case, patients are going to present with worsening of abdominal girth and pain, hypotension, and anemia. The most common extrahepatic metastasis of HCC is to the lung, intra-abdominal lymph nodes, bone, and adrenals respectively. And of notice, the brain tumor is a rare extrahepatic manifestation of HCC. So that's all about hepatocellular carcinoma. If you like the video, please like, subscribe, and comment. Thank you.